This is the intra-aortic balloon pump transport simulation video intended to help staff view what these transports are like. Please refer to the most recent intra-aortic balloon pump transport quick guide for complete guidelines. On arrival to the cath lab, you will want to receive handover from the cath lab team and the interventional cardiologist on the patient's history and clinical course. At this time, you will help stabilize and prepare the patient for transport. When EHS arrives, the patient will be slid over to the stretcher. EHS will bring stretcher number 9, which fits the pack rack. Prior to moving, this is the optimal time for the RN to lead a pre-transport timeout to optimize patient safety. This should include verifying the roles and responsibilities of each team member, ensuring all tubes and lines are being monitored, determining who will do the count prior to moving, i.e., 1, 2, 3, move. This will typically be the RT or the interventional cardiologist as they have the most invasive lines to monitor. As well, they need to confirm the cardiac arrest plan with the interventional cardiologist. After the patient has been moved to the stretcher, begin to secure the pack rack. The pack rack needs to have at least 1 foot sitting on the stretcher's metal frame, not the purple leather fabric. The white monitor securement device should be over the right leg of the patient to ensure that you can visualize the monitor in the ambulance. Ensure that the IAB tubing is on the outside of the pack rack. If you do not do this, you will not have enough slack when inside the ambulance to secure the IABP. Consider wrapping the patient so that you can easily move blankets to view the IABP insertion site. Secure the defibrillator. Then secure the IV pumps. The pack rack can only fit maximum 2 pumps with 4 channels or 1 IV pump and 1 transport ventilator. Discuss these options with your RT. Prior to leaving the cath lab, it is recommended that the interventional cardiologist should print the IABP monitoring waveforms and analyze the timing prior to leaving. As well, they should reprint and analyze timing if there's any timing concerns. Patient transfers are the most risky procedure for dislodging the balloon. The team should move together to prevent any accidental tube dislodgement. Ensure that the RN has a view of the monitor during the entire transfer. The IC will continue to monitor the IABP console. Travel carefully to the service elevators. The ambulance will be at the critical care tower basement level EHS bay, not the emergency department ambulance bay. When you exit the service elevators on basement level, you will head left through the doors and the ambulance will be there. The EHS crew will prepare the stretcher for loading. This is a critical point to verify that all lines are being monitored. EHS will load the patient into the ambulance in unison with the intra-aortic balloon pump. They will manually lift the balloon pump. It is very heavy. This is another view of the EHS crew members lifting the intra-aortic balloon pump in unison with the stretcher. EHS is responsible for securing the intra-aortic balloon pump to the seat. This is the only location that it can be safely secured. The IABP screen can be rotated for viewing. You can see it is in the screen circle at the top. In this picture, the screen is actually folded down, but in reality, it will be folded up and then the screen can be turned to face the interventional cardiologist. At this time, the interventional cardiologist will also be assessing the level of the transducer for the intra-aortic balloon pump if they are using a non-fiber optic balloon. We are most likely to use a fiber optic balloon at the Surrey Memorial Cath Lab. However, we can't always confirm that that will be done, and that will be the responsibility of the interventional cardiologist. Once the patient and the IABP are loaded, staff will need to find the seat most appropriate for their role. There is limited seating in the ambulance as the IABP is secured to one of the staff member seats. This means that in smaller ambulance, there will only be room for one RN, one interventional cardiologist, and one RT or another team member. On arrival to the receiving site, the patient will be unloaded in unison with the intra-aortic balloon pump coming out of the ambulance. The team will then transport the patient to the receiving unit and provide handover on the aspects of patient care they were responsible for. Questions, reach out to your CNE.